Good afternoon and welcome back to Bariatric Friday. Today we are diving into a hot topic that's been on many of our minds: the battle against obesity and best way to tackle it. Weight loss drugs and bariatric surgery are the two major contenders in the weight loss arena. Which one is more effective? What are the pros and cons of each? Who should consider which options? We will break down the facts, share experts' insights. Dr. Irgau is with me. So whether you are considering these options for yourself, or just wanted to stay informed, just follow us and enjoy the conversation. Dr. Irgau, how are you doing?
I'm doing great, Kemal. How are you today?
I am doing good. Today is weight loss drugs and bariatric surgery. Although in our introduction I said it's like if it's an option, one is an option for the other one. That actually is not the case. So and that's one of the reasons that we want to actually discuss this topic, to educate public and understanding how weight loss drugs should be used, where it should be used, what are the places that's most effective. But one thing that we know that is not an alternative to the most effective tool to fight morbid obesity, that would be the bariatric surgery. Now, many people, they think that we would be against weight loss drugs. That's not really the case, because we want morbid obesity to be understood as a chronic illness, and then every medical profession in their offices, when they see patients or people who are going through these troubles in their lives, they can understand and know that this is an illness and they need to seek for options to fix this problem. Now, weight loss drugs is making this kind of highlighting the issue a little bit more, because we know that this is an illness just like the diabetes and others, so it should be treated, and there's best times and best places that we can actually utilize. So now, before I go into too much in these, just want to get your overall opinion on what your patients are telling you, and also what it is that weight loss drugs do versus bariatric surgery does.
Yes. So essentially what you said in your introduction is important, Kemal, because we are treating a chronic illness, a chronic disease here. So that's the bottom line. We have to all agree on the issue that morbid obesity is a chronic disease. It is a very, very difficult problem to tackle. A lot of people, probably the greater part of our society, hasn't really come to grips with this reality, that this is a disease, that we are fighting a battle that is really, really hard, particularly for the individuals that are suffering from morbid obesity. And people may ask why that is. What is the reason? Why is it so hard to lose weight? And probably the most straightforward answer to that would be because we have a body that is designed specifically to hold on to weight. Our body basically does not know how to lose weight. Every time we lose weight, we try to lose weight, it thinks that something bad is happening to us, and it wants us to go back to the weight we were before or to gain more weight, right? Now, we can argue and discuss as to what was the advantage for us as human beings to have such a body. And the answer to that probably lies in looking at our evolution as human beings over, millions, over thousands of years, where our main threat to survival was lack of food. So it was very advantageous for us to have a body that was able to hold on to energy for as long as possible whilst we were struggling to find food. Well, in the last 100 years, we have transformed our societies in the vast majority of the planet, where food is easily available. In fact, in places like our country in America, food is abundant, overabundant, right? In this situation, having a body that holds on to weight and does not know how to lose weight creates the epidemic that we have. It is no surprise, Kemal, that the rates of obesity in the United States right now have reached close to 40%, right? That's really, really very high. And if it was just a question of weight, okay, you're carrying more weight, okay, you need more clothes. If that was the issue, Kemal, we would not be here talking about that. The problem is that having extra weight actually leads to real diseases like high blood pressure, like type 2 diabetes. And like we were talking about last time, it actually puts us at risk for cancer development as well, right? So it is a serious life-threatening condition, essentially, when we look at it that way. Now, if there is no hope in tackling this problem with diet and exercise, it is obviously imperative for doctors to be involved in helping people lose weight. And the question that we're discussing today would be, would medicine be better? Would surgery be better? Well, there is no such dichotomy, really. Both are good and appropriate in the appropriate circumstances, right? When we are treating cancer, Kemal, we don't say, oh, should I do chemotherapy or should I do surgery, right? We go to the specialist and we listen to them and say what is appropriate in this stage. Well, the specialist very often will say, well, it depends on the type of the cancer. It depends on the stage of the cancer, whether it's advanced or not. And in some cases, they may even say, hey, we have to do both. We have to do chemotherapy, which is medication, and we have to do surgery. And this is what we have to come to grips with morbid obesity as well. Right now, we are very fortunate right now because we live in a time in which we have more than one effective treatment for different levels of morbid obesity. Clearly, it has been established now without any doubt that for severe types of obesity, surgery remains the gold standard, right? Why is that? Well, because it gives excellent results, it gives long-term results, and also the potential for complications and risks has been reduced to a very low level, right? So that is our to-go treatment. But also, we are very excited because we are seeing development of new medications that are coming up now to help us. Mm-hmm. If we were having this discussion like 5-10 years ago, Kemal, we would be talking about drugs that at the most would be helping people to get maybe 5, at the most 10% weight loss, right? Which means that 5-10 years ago, if you try to do medications for somebody who is, let's say, 300 pounds in weight, at the most, they would be able to get 30 pounds off, right? So from 300, they would come to 270. For somebody who is about, 5'5", 5'6" in height, that weight loss is good, but it's not going to be sufficient really for them to have dramatic results. So when you have somebody who's 5'5", 5'6", and they are 300 pounds, definitely surgery was the answer. Well, now we have medications that actually can do better. Now these medications that we have, they are a class of medications now known as GLP-1 receptor agonists, essentially. These medications have been shown to help people lose even 15%, even 20%, and sometimes 25%. Weight loss in some patients, which means that if somebody was 300 pounds, now they could be looking to losing even as much as 50, 75 pounds, which is significant, essentially, right? Now, obviously, we have to see that those results don't happen in every individual with that reproducible outcome, but there are patients who have been shown to lose that much. So clearly, we have to look at medications as an option, right? But the best way to look at them, at least from us, and we consider ourselves not necessarily just surgeons, Kemal, we consider ourselves metabolic specialists, which means that we are really interested in the weight loss, whichever way we can accomplish it. So we look at them actually as options that are best in specific circumstances, right? So if you have somebody, for instance, who is, 210 pounds and they need to lose 20, 30 pounds, that patient might be better off with medications because probably depending on their height, their body mass index may be 32, 33, right? But if you have somebody who is 350 pounds, Kemal, right? And they need to lose 100 pounds, they need to lose 150 pounds, clearly surgery is the best option for them. Right? So just looking at the weight loss, this would be the thinking that would come up, right? But beyond that, we have to look at the long-term effectiveness. So far, what we have seen, Kemal, is that when patients are placed even on these powerful medications, they have to stay on those medications almost indefinitely for that weight loss to be maintained. what the studies have shown is that when people actually get off the medications, the weight tends to come back.
Can we repeat that again? So they have to stay on it.
That is correct.
For
yes, absolutely.
Forever.
Well, indefinitely, right? And also, obviously, like any medication, come on, there is, the side effects that we know and the side effects that we don't know, right? Because when you do trials and you do testing, Kemal, you do testing not for a lifetime. You do testing maybe for a year and a half, at the most 2 years on that medication. So you will see what kind of side effects a person might have during that period of time. But when you start having somebody on a medication for 3 years, for 5 years or longer, then you're going to get into situations where now it's the unknown, because you don't know what the side effects might be, because you haven't had the chance to study them that long. So yeah.
Actually, let's take a little pause there. So because this is important. So we are. I'm going to repeat this because I know people understand this to kind of like perception is blocking them to understand. We want weight loss drugs to be utilized as a bariatric program. But what you said is extremely like really good example of like the cancer where there are treatment options based on where you are.
Yeah.
So now I look at our actual schedule list right now. Now, someone with BMI 55, they're about 375 pounds. So doing medication treatment for this patient is going to take them from 375 to maybe 310. They're going to be still morbidly obese while they're going through with that medication. Now, another patient with, of course, with the height and weight, these things are changing. So someone with 60 BMI, they're at 383 pounds. So now these are our cases. Anything over 40 is kind of severe at this point.
Yes.
Now, we believe that medication can be used in conjunction with the surgery to actually maybe get even better results.
Yes.
If it's necessary,
yeah.
right? So that's kind of important. And I think this cancer comparison, we need to really make people understand that is kind of, that's it. So like you and I, we talk about my weight journey and on my own, I'm able to gain and lose 20, 25 pounds on my own without any, like, I'm not just saying losing, but also gaining.
Right.
So that means I'm kind of in charge of that by making adjustments in my lifestyle and diet. But if I really want that to be maybe a little bit long-term, then I may be on that medication. So the level is where this is where we can actually tackle the problem early on, then maybe not becoming a bigger, more major. So that's why I don't think we are ever gonna say that weight loss surgery is on one side and the weight loss drugs are on the other side. They are actually on the same side. So that's kind of needs to be very clear for everyone. So now this being on the medication for a long term, now like average is about like 15% of weight loss. These people, they get this result after 6 to 8 weeks, so a little over a year. And then to maintain it, they have to stay on it. So that's another really big issue that you are mentioning. So for our patients, they don't have any time to lose. So once they're on the bariatric surgery program, they're at that severity is like at the highest level where we have to act on it as quick as possible to get the best result. So now the side effects that you were going into, if you can just go over the side effects of the weight loss drugs. And then my question would be, after you explain those side effects may be more severe for someone who's at a higher BMI because of the situation that their body is already in. But I'll see what side effects we have, and then we'll go from there.
Sure. So this, particularly the newer types of medications, Kemal, are very powerful medications that help people by suppressing appetite, by making them feel full early, by delaying gastric emptying, which is, the stomach after you eat empties very slowly, so it stays full longer. And also they have a beneficial impact on the metabolism of the person. And the metabolism is that process whereby our body transforms the fuel, which is the food that we give it, into utilizable energy, essentially. So that process is controlled finely by our body, and it's biased towards conservation of energy or storing of energy. That's why it's very hard for us to lose weight, essentially. But those medications actually can favorably affect that, so that the person can start losing weight. Particularly the newer type of medications, they're called GLP-1 receptor agonists, essentially. They mimic a hormone that we have in our body, but this hormone in its natural state in our body, it just stays for a very short period of time in our bloodstream. And these medications are now designed to keep this mimicking chemical into our body for longer, so that the appetite and the suppression of appetite, the slowing of the stomach emptying, can last longer. Now, from the get-go, there are some patients who cannot tolerate that. For instance, the slowing of the gastric emptying can cause nausea, can cause sickness, can cause abdominal bloating and pain, so that they would not be able to tolerate. For some patients, the symptoms can appear later, perhaps with increasing doses of these medications, and they may not be able to proceed to levels that are needed for them to lose weight adequately. Now, sometimes some patients can present with very serious gastrointestinal complications, whether it's inflammation of the pancreas or the gallbladder, or things that would really not allow them to continue with these medications. In certain instances, there is concern that the risk of cancers, of some type of cancers, could be increased. In fact, doctors, before they prescribe these medications, will screen patients to make sure that they are not at risk of developing these problems, essentially, as they prescribe them. And then, obviously, as we always talk, it's important to follow up the patients on a regular basis, right? And then, obviously, the other thing that one should not forget is that, and this is probably very important for people who just buy these medications online or through dispensaries, is that you have to be within a program that has the necessary components, of weight management, whether it's nutritional counseling and other, monitoring of one's health, essentially. So there are patients on whom the medications may not be appropriate from the get-go because they may develop these complications, or there may be patients who may develop the complications later, or there may be concerns about some type of cancers, as I mentioned before. So the question, obviously, is that once you start the journey of administering this medication, whether it's the newer, once-a-day oral medications or the injectables that people have to take on a weekly basis, once you engage in that process, Kemal, then long-term, and as I said before, for every medication that we use, there are always complications that we may not have known about. This is just part of how our body works. And so we have to be vigilant, particularly when we are administering this medication for 6 months, 1 year, or longer than a year, because just there is a lot of unknown from that perspective, okay? Now, one could argue that maybe you could utilize those medications to get a person to a certain level, and then you can use diet and exercise. But one thing that people need to understand is, again, our body is extremely good at returning at a previous weight. It almost is as if it develops a memory that once it has known a certain weight, it wants to go back there, right? And that is very, very difficult to fight. One area of treatment that has really overcome this problem is surgery so far, because we have patients on whom we've done surgery 20 years ago, and they're here after they've maintained their weight loss. And I'm saying they are here really specifically because many of those patients may not have been alive now had they not had bariatric surgery 20 years ago, when they were at the really severe end of obesity with difficult to control high blood pressure, difficult to control blood sugar, severe sleep apnea, and many other medical problems. So surgery, we have long-term experience showing us that it is really effective and effective in the long term, particularly for the severe types of morbid obesity. Now, like we always say in our discussions here, even surgery, however powerful it is not something that people cannot defeat. There used to be a bariatric surgeon that is now retired in Princeton who used to say, you can out-eat any bariatric procedure, meaning that if you really try very hard, you can defeat bariatric surgery as well, particularly if the focus is lost, right? So knowing that, we're very happy about the availability of medications because we can provide that. So providing medications to somebody who's had bariatric surgery, we don't consider that as a defeat, Kemal. We consider that as a very, very good appropriate tool that we have right now.
Absolutely.
Pretty much going along the analogy of the cancer that we talked about, right? Somebody develops a colon cancer, surgery is done to remove that cancer, then they have an X-ray or a CAT scan or a PET scan, 2-3 years later, and spots are noted in their liver or somewhere else in their body, the cancer coming back. What do? You use chemotherapy, right? So that's not necessarily the failure of surgery, it's the aggressiveness of the disease that demands more tools than what we have. And that is our role as well. So as good providers, we should not be applying the same and only treatment to all individuals because we're all different. That is why when you and I are presenting this session, Kemal, we are not really providing treatment to individuals. We're providing education. Treatment to individuals is provided by their specific doctor or surgeon. So because everybody's situation is going to be different. What is important for us to come to relate to people is that there is hope. There is a way out of morbid obesity, much better than ever now, because we have surgery and we can add medications to that as well to make sure it remains effective. So that is why, at the beginning of our discussion, it was important for us to specify that we're not talking about two divergent or even contrasting roads when we're talking about surgery or medications. We're talking appropriateness of each option in different situations, and also situations in which both combined may even be necessary to help people out.
So that's one of the things that I'm hearing from what you are explaining. Our body has certain settings, and then it wants to go back to those, and it doesn't have to be the right one for us. So I guess it just works differently than the way that we want it to work. So now the issue is unless there's a structural change on that setting, then going back to where we started is most likely going to happen. So without the structural change, things can happen, but it's not going to be as easy, or is not going to be as likely, I guess. So, and then with one of the things I always remind people, like part of the stomach that we are taking out is the part that also makes us more hungry.
Yes.
Right? That's a structural change.
Yeah.
I say structural change, just the lack of term. There's a change on that. I'm not saying that structural change in a way that, between the bypass versus sleeve, it's not that type of a structural change, but on the design, there's a change because we are taking a big part out where it's kind of responsible to communicate with the brain, and then I'm hungry, I need to eat more, this and that. Now, that's kind of important for people to understand. My other big concern, Dr. Irgau, is the patient expectation, and also in some cases, how healthcare professionals are approaching the issue. The reason I'm saying this is because you are not going to take this pill and start losing weight tomorrow without making any other changes. That is not the case. So let me just repeat that. So you have to make lifestyle changes and diet adjustments for that medication to get to the maximum results. So meaning that just like when I repeated in our sessions, bariatric surgery also is not a magic. But when it comes to the medication, the issues are, well, if your expectation is, I'm not going to change anything in my life, I'm going to start taking this pill and boom, I'm good. No, that's not the case.
Yeah.
So now, just like the patient with diabetes doesn't eat like a gallon of like ice cream and then take their medication and then expecting that medication to work, right? So they are still on a special diet, at least most of them. So, so that is kind of like that needs to be explained. And then I'm going to also, ask healthcare providers whoever is listening to this to make sure that they take they make responsible decisions to guide the patient. So it shouldn't be just like, oh, here's your diagnosis and then here's your medication. That patient is going to pay a lot of money and they're going to wait for a long time to see any results, which it may not be happening. So it has to be done by those who are really understanding the weight loss management, and that's why there's a board certification for weight loss for those primary care physicians, and we have one of those individuals, Dr. Vani Singh, and I look at her approach versus any others, and she's actually tackling the issue from the weight loss side. She's not just writing the medication and then say goodbye to the patient. There is a plan of action. There's a standard treatment options for weight loss. Unless we follow that, it's not going to work. So that's kind of like really important for not just patients, but everyone whoever is listening, for them to really understand. Because we don't want that failure to be kind of like blaming the medicine. Medicine is going to work,
right,
but you have to walk. Medicine is going to work, but you have to cut off cut off your diet. So you can, I share my diet log where I have a specific field for whether or not if I had ice cream or milkshake that day. So because that's kind of like that's a deal breaker for me. So if I can go through the week without having one, I feel kind of like it's satisfying, rewarding in a way. And the reason I'm putting that reminder to myself because I know it won't change. I won't get to where I need to be unless I make that change. So that's why it's kind of like really important. Anything else that we didn't maybe?
Well, I mean, I would like to emphasize this last point that you made, which is, there has to be a programmatic approach to tackle this problem, right? And we are saying this because we know the gravity of the situation. In other words, we're not tackling a simple problem. It is not an statement to say that treating morbid obesity is probably one of the most challenging things that any doctor can try to do, particularly where we live, right? So we have to use every edge, every advantage we have to try to get there. So we have seen, as I said in the introduction, that diet and exercise don't work, particularly for people who've reached really very high levels of weight, right? But when we say they don't work, we're not saying replace them completely with this pill or replace them with this surgery. What we're saying is to the diet and exercise that has disappointed you all these years, you have to add something more powerful as a tool, as an avenue, right? So that's what we're saying. So you do not want to stray by going back to eating, empty calories, drinking empty calories, or leading a totally sedentary life and expect the weight loss results to be good, no matter how great the surgery, no matter how powerful the medication. That foundation of healthy diet and exercise has to remain. But another point that people fail to understand is that this is a habit that is not easy to implement and also to persist on, right? Which is why you have to have a support system that has dedicated professionals, whether it's nutritionists, whether it's psychologists, whether it's nurses, surgeons, and other doctors to support the person. So one of the things that we do in our bariatric program, Kemal, is that when we have people signing on for the surgery, we actually make them sign a contract which tells them they are obligated to follow up with us for the long term, right? And we're not saying that because we want to tie them to some type of contract. We're saying that because we know the long-term outcome very much depends on that, right? If they see us on a periodic time, then we will be able to support them early when they started to slide, right? When the weight starts coming on, instead of them coming back to us after they've gained significant amount of weight, if they come to us early, then we'll be able to support them. Right. Because all of us could be victims of, stresses and other things that could take our focus away in different times of our life. So
it's average, Dr. Irgau, it's average about 10% higher on the BMI when patients are coming back to us, when they don't go through first time. When they come back a year or 2 years later, I specifically check to see what has happened to them. I can put probably $100 on the bid for 10% minimum.
Yeah,
I
absolutely.
haven't seen anyone who came back with weight loss or kept the same weight. So it just gets worse. Just like any other illness that's not treated. I mean, the thing is, it's so simple. So if I have diabetes and if my A1C is 9, and if I haven't done anything, waiting for 2 more years, it's just going to make everything worse. It's the same thing. So you have high BMI, you have morbid obesity, you don't do anything. I mean, if you try to do certain things in between, fine. But if you haven't done anything, it's just going to get worse. That's simple. Yeah, so that needs to be kind of like really understood. The other thing is that weight loss drugs are so expensive.
Right.
Yeah. It's extremely expensive. It's about $1,200 to $2,500 a month. Now, your insurance may be covering, maybe, but most of them are not. But when they are covering and when you don't see the result, those insurance premiums are going to come back to you in 2 years with all those costs that we wasted. So that's another really important issue. Use them wisely, use them with a program.
Yes.
Use them with those healthcare professionals who understand morbid obesity, and you'll definitely see results because, again, only 1% of the patients who are qualified for bariatric surgery are getting bariatric surgery. This is not a concern about, oh, are we losing business? No, that would be totally dumb to think like that. Because our goal is to make everyone understand that weight loss, morbid obesity is a chronic illness. So while we are saying this, if there's a treatment option other than surgery, we are, of course, going to welcome that, which we do. And we use in our programs, like a patient with 64 BMI needs to go down to 57, maybe in some cases. And to speed up the process, we may take advantage of the medication. So hopefully, those who are interested in this find this helpful. So that's what we have to say for today. Dr. Irgau, again, thank you for joining me, and we'll see you guys soon next week.
Thank you. Have a nice weekend. Bye-bye.